So hello everyone and welcome to the case 8 of this Osce series, and today we'll be discussing a very interesting case. So here we have a 30-year-old male who came with complaints of acute pain and tenderness in the left iliac fossa, and I did the ultrasound first of this patient and I found some omental thickening in the left iliac fossa, and I ordered a CCT abdomen for further evaluation. And these are the contrast enhanced images, axial section of the abdomen. So he has a history of appendicectomy done. Now he complains of pain in the left iliac fossa. So here is where I found that there was some omental thickening, and on CT also we can see some fat density with peripheral rim of enhancement that is seen in the right iliac fossa adjacent to the sigmoid colon. These are the coronal images of contrast enhanced CT scan, where again we can see this fat density with peripheral rim of enhancement, the left iliac fossa adjacent to the sigmoid colon. So what do you think the diagnosis is based on this particular CT? So this is the report that I had given for the CT scan. An ovoid structure of fat density was noted in the left iliac fossa adjacent to the sigmoid colon with thin peripheral rim of enhancement. There was mild surrounding inflammatory stranding which was seen with adjacent peritoneum thickening. There was no significant thickening of the colonic wall or any outpouchings from the wall, hence ruling out diverticulae or diverticulitis as a cause of this condition. So the diagnosis is epiploic appendigitis here. So the CT characteristics of epiploic appendigitis include a fat density ovoid structure adjacent to the colon with a thin high density rim, hyperretinating ring sign it is called. This ring actually enhances on post contrast images, which was seen in our case. There is surrounding inflammatory fat stranding and thickening of the adjacent peritoneum, and a particular central dot which represents a thrombosed vascular pedicle. The adjacent colonic wall is usually not thickened, but if it is present, it is usually minimal. The inflamed appendage is classically located anterior aspect of the sigmoid colon or the descending colon, which was there in our case. And chronically, an infarcted epiploic appendigitis may calcify and detach, giving a calcified intraperitoneal loose body called peritoneal mice. So this is actually a peritoneal mice. These are peritoneal mice. Sometimes we see some calcific densities within the abdomen, and we can't determine the cause. So this is actually the cause. This chronic epiploic appendigitis. So coming to the pathogenesis, epiploic appendigitis usually occurs because of inflammation of one or more appendices, epiploicae, which number 50 to 100 and are distributed along the large bowel with variable frequency, most commonly in the rectosigmoid junction. The pathogenesis is thought to be due to torsion of the large and pedunculated appendage or spontaneous thrombosis of the venous outflow, hence giving that central pedicle sign, which results in ischemia and necrosis.